Preoperative diagnosis is right knee medial and lateral meniscal tears, right knee plica syndrome, right knee Hoffa syndrome, right knee synovitis. Postoperative diagnosis was right knee medial and lateral bucket handle meniscal cartilage tears, Hoffa syndrome, synovitis, and plica syndrome. So you look at meniscus, just the outer third or outer 20% has blood supply. And then as you go more in, it's avascular. So if you get a tear out in this area, we call that the red on red region because it's vascular, and you can repair it. If it's torn where the vascular part meets the avascular part, we call that red on white. And then if it's torn in the avascular, we call that white. So that is just totally trash. That's the whole meniscus. That is not coming out. This gap in the candidate for a meniscal transplant. So we got to go back and read the MRI. The indication for the operation, a 26-year-old male sustained an injury to his right knee, resulting in bucket-handled medial and lateral meniscal tears. Treatment options were discussed with the patient, and after a long discussion of the risks and benefits of both operative and non-operative care, the patient elected to proceed with surgery. Brief description of the operation: the patient was identified by name, given preoperative antibiotics, taken the operating room, general anesthesia was administered. The right lower extremity was placed on an arthroscopic leg hold, was prepped and draped in standard sterile fashion. The knee joint was injected with 10 cc's of 1/4% marking with epinephrine. A standard inferior medial and inferior lateral arthroscopic portals were established. Diagnostic arthroscopies performed. All right, so you got the wooden planks that tank the barrel, and you got the metal boots. For the more pressure you put on the inside pushing out, the more that boot stress pushes back in. So that's the way a meniscus works, is it's got longitudinal collagen fibers that act like a weak flat boot stress. So when the thigh bone pushes down, it evenly distributes force. If you get a tear that just goes straight back, you don't have to lose the whole meniscus as long as you disrupt the longitudinal fibers that the meniscus can function. Procedure performed was right knee arthroscopy with partial medial meniscectomy, partial lateral meniscectomy, plica resection, resection of Hoffa's fat pad, partial synovectomy, and platelet-rich plasma injection. Anesthesia was general. Blood loss minimal, complications none. Synovitis in the suprapatellar pouch in the medial lateral borders was debrided extensively using a shaver and a radiofrequency probe. He had no condylarthrasia on the undersurface of the patella or in the intertrochlear groove. He had fibrotic retropatellar fat pads consistent with Hoffa syndrome, and that diseased tissue was removed using a shaver and a radiofrequency probe. His plica was removed using a shaver and a radiofrequency probe. I then turned my attention to the medial compartment, where he's noted to have a bucket-handled medial meniscal tear involving 90% of the inner margin of the entire medial meniscus. The bucket-handled portion was so damaged and macerated that it was irreparable. I then used a basket and a shaver to perform a partial medial meniscectomy using standard technique. He otherwise had no condylarthrasia on the medial femoral condyle or the medial tibial plateau. The ACL and the PCL were intact. He also had a bucket-handled lateral meniscal tear involving approximately 20% to 30% of the inner margin of the lateral meniscus, and that was debrided back to stable tissue using a basket and a shaver. The popliteus tendon was intact. The popliteus hiatus was intact. There was no significant condylarthrasia on the lateral femoral condyle or the lateral tibial plateau. At that point, the instruments were removed. The pearl sites were closed using 2-0 monochrome in a subcuticular fashion. Stereostrips were applied. The knee joint was injected with 5 cc's of platelet-rich plasma obtained from the patient prior to the start of the case.